I Assalamualaikum warahmatullahi wabarakatuh. Good morning, distinguished guests. Our guest of honor from Duke Eye Center, Professor Lloyd Williams, MD, PhD, James Yun Botian, MD, Dr. Shin Yes. Sorry for our technical difficulties. Uh, Good morning, distinguished guests. Our guest of honor from Duke Eye Center, Professor Lloyd Williams, MD, PhD, James Yun Bo Tian, MD, Dr. Shin Song, DO, and team, Director of Service Strategy, Planning and Development of Chipto Mangunkusumo National Hospital, Dr. Bobby Prabowo, Consultant in Emergency Care. Good morning, distinguished guests. Our guest of honor from Duke Eye Center, Professor Lloyd Williams, MD, PhD, James Yun Bo Tian, MD, Dr. Shin Head of Ophthalmology Department, Dr. Ari Jati Kusumo, Consultant of Ophthalmology. Head of Corneal Transplant Collaboration Program, Dr. Farabi Martha, Consultant of Ophthalmology. Head of the iBank Chipto Mangunkusumo National General Hospital, Dr. Lina Ladistianora, Consultant of Ophthalmology, PhD, and representatives of the RSM Education and Training Team, and all the respected professors, esteemed colleagues, and fellow ophthalmologists. My name is Ayesha, and it is my honor to welcome you to the Corneal Transplant Collaboration Program, a joint initiative between RSM Kirana and Duke Eye Center. Over the next 2 days, we will embark on a journey of knowledge exchange, sharing best practices in corneal transplantation and strengthening international collaboration in ophthalmology. Without further ado, let us begin our program with the welcoming addresses. Please welcome Dr. Rina Ladistianora, Consultant of Ophthalmology, PhD, Head of the iBank Chipto Mangunkusumo National General Hospital, to deliver the opening remarks. Dr. Rina, we warmly invite you to take the stage.
Good morning. Assalamualaikum warahmatullahi wabarakatuh. Thank you everyone for your attendance to this morning's visit. And on behalf of the iBank of RSCM and also Ophthalmology Department of RSCM, we would like to welcome all of you to our Jakarta City, to the Duke Eye Center team. We are very welcoming you because we are excited to have this meeting, this 2 days meeting here. So we are very thankful to the Board of Directors, Dr. Bobby, for coming here. Board of Directors has been fully supporting us in our ramah donor culture. It means that we are very friendly to donor culture here in the hospital, and there are a lot of programs that we plan to have because we want to have the hospital corneal retrieval program. We are very hopeful that this program will come hand on hand with the transplantation program because we have a wonderful corneal surgeon here that need to be trained more and more to become more expert, like Dr. Lloyd Williams, or maybe even more, yeah, Doc? Hopefully more. Also, therefore, their visit really represent the kindness and compassion a human being can have. As we know, Dr. Williams has visited so many places like Africa, and even the first corneal transplant in Sierra Leone. I think his stories are very touching to our heart. That's why we are very eager to start our program here in all over Indonesia and collaborate more. Like we already have collaboration with Sarjito Hospital. So this is wonderful. I hope this program will inspire us, strengthen our teamwork, and move us closer to our shared mission to overcome the corneal blindness in all over the world. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Rina Ladiscanora, for the inspiring words. Next, we are honored to have Dr. Ari Jati Kusumo, Consultant of Ophthalmology, Head of the Ophthalmology Department at RSUPN Cipto Mangunkusumo, to share his welcoming remarks. Dr. Ari, the stage is yours.
Yang terhormat Dr. Bobby dari Direktur Pengembangan Strategis Layanan, Profesor Hanifah, Ketua Tim Transplant RSCM, dan Kepala Instalasi Kirana, Dr. Nina, dan Profesor Dokter sekalian. Good morning. Assalamualaikum warahmatullahi wabarakatuh. It's our great pleasure to extend our warm welcome to Professor Lloyd and teams from Duke University. Who join us today in this collaboration training corneal transplant program. So it's a great honor for us, to have you here with your experience and also your expertise, in this field of corneal transplant. I think it's very invaluable to our staff here and also to our patients. So and this program, I think, is represent our good opportunity to us, to improve and to enhance our skill, and eventually to also to improve our eye care, to especially to those who need the corneal transplant. And together I think we can strengthen our understanding and our collaboration, to improve our especially our skill and to improve the eye care quality in for our patients. And really thank you, and also for being here. And so sorry to kidnap you here all the way here from US to Indonesia. I hope you enjoy your stay here, and we are looking forward for this engaging and exciting program training and also the lecture today. Thank you very much.
Thank you, Dr. Ari, for the motivating message. Now we would like to welcome to the stage the representative from the Board of Directors of RSUPN, Dr. Cipto Mangunkusumo, Dr. Bobby Prawobo, Consultant in Emergency Care, Master of Biomedical Sciences, as Director of Service Strategy, Planning, and Development of Cipto Mangunkusumo National Hospital, to deliver the welcoming speech. Dr. Bobby, we warmly welcome you to the stage.
Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi semua. Yang saya hormati Kepala Departemen Ilmu Kesehatan Mata FKI RSCM, Kepala Bank Mata RSCM, Prof. Selamat pagi, Prof. Hanifah, Ketua Transplant RSCM, dan para pakar dan juga mungkin presiden ya, presiden yang hadir di sini, and our esteemed colleagues from Duke University, Eye Hospital, Prof. Light Williams, Dr. James Tian, and Dr. Sim Song, with team, dan seluruh hadirin yang saya banggakan. Sebelumnya marilah kita panjatkan puji syukur kehadirat Tuhan Yang Maha Esa, karena berkat rahmat dan karunia-Nya kita dapat berkumpul bersama dalam acara Corneal Transplant, kolaborasi program antara FUI dan Duke University Eye Hospital pada hari ini. On behalf of the Board of Director of RSPN, Dr. Cipto Mangunkusumo, it is my great honor and pleasure to welcome all of you to this important event. We are truly grateful to have world-class experts from Duke University with us today, who will share their knowledge and expertise through lecture, case discussion, and a live corneal transplantation surgery demonstration. Kami berharap kegiatan ini tidak hanya menjadi ajang pertukaran ilmu, tapi juga menjadi awal dari kolaborasi jangka panjang antara FKUI, RSCM, dan Duke University. Dengan kerjasama yang erat, kita dapat memperkuat layanan kesehatan mata di Indonesia, meningkatkan kualitas pendidikan kedokteran, serta memberikan manfaat nyata bagi para pasien yang dibutuhkan. Tadi sudah ngobrol-ngobrol dengan Dr. Rina, bahwa sebenarnya opportunity-nya banyak sekali. Hal ini mungkin perlu kita dorong di Kementerian Kesehatan, Prof. Karena ternyata potensinya besar. Bukan hanya nanti mata, tetapi nanti juga donor organ yang lainnya. Dan nanti siang mudah-mudahan kalau misalkan kita bisa bertemu, dan kalau bisa nanti ke depan juga kita presentasi di Pak Menko, agar dengan ini luar biasa. Mulai dari mata, dan kemudian nanti masuknya mulai dari Departemen Oftalmologi, kemudian menyusul yang lain. Mudah-mudahan kita semangatnya tetap sama, dan ini menurut saya momentum ya, momentum Prof. Dokter sekalian, dan ini juga bisa menjadi acuan di Indonesia, karena tadi Prof bilang ini bukan RSCM, ini Indonesia. Saya rasa kita punya semangat yang sama, berawal dari Dr. Mina berharap bahwa pusat klasik Indonesia mulai lagi, kemudian diawali lagi nanti Januari-Februari itu pelayanan yang lain. Nah, tadi itu kok bicara mengenai transplant. Nah, ini luar biasa sekali, ada 2 program besar ternyata Pak, yang akan kita bawa ke depan untuk mengembangkan Departemen Oftalmologi yang di RSCM, yang harusnya ini punya Indonesia, bukan lagi membawa atas nama RSCM, tapi membawa nama Indonesia. Akhir kata, kami mengucapkan terima kasih kepada seluruh panitia yang telah bekerja keras mewujudkan acara ini, serta kepada tamu kita, our distinguished guests from Duke University, for their valuable contribution. Semoga program ini berjalan lancar dan membawa hasil yang bermanfaat bagi kita semua. Demikian, wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Bobby, for the warm remarks and for your support towards the advancements of ophthalmology. Ladies and gentlemen, we will now proceed with the photo session and the presentation of the certificate and plaque of appreciation to our distinguished partners from Duke Eye Center. First, we invite Dr. Bobby Prabowo as the Board of Directors to present a plaque to Professor Lloyd. We'll give a moment for the documentation team to capture this presentation. To Professor Lloyd, we welcome you to the stage. 3, 2, 1. Next, the Board of Directors will also present a certificate and souvenir to Professor Lloyd. Once again, we'll pause briefly for documentation. 3, 2, 1. Yeah. Welcome the Duke team to the stage to take a picture. Also invite Dr. Sheena to come forward to receive the certificate and souvenir presented by the Board of Directors. Finally, we would like to invite all participants to join in for a grand group photo to commemorate today's event. May all the staff join the team on stage for documentation. Everyone smile for the cameras. 3, 2, 1. One, two, three. Smile for the camera. 1, 2, 3. 1, 2, 3. 1, 2, 3. May we invite all participants and residents to join the stage for more documentation. We invite all residents and all participants to join the stage. May all participants move forward to the front of the stage. Everyone smile for the cameras. 1, 2, 3, smile. 1, 2, 3, foto. Okay. Okay. Thank you to all residents, staff, and participants for your participation in photo taking. This concludes our photo session and the presentation of tokens of appreciation. We kindly invite all participants to return to their seats. Thank you to all participants. Now it is time for our first guest lecture series. The topic is Best Practices in Posterior Lamellar Keratoplasty, presented by Professor Lloyd Williams, MD, PhD from Duke Eye Center. And this session will be moderated by Dr. Jessica Zarwan, Consultant of Ophthalmology. Allow me to first introduce our moderator. Dr. Jessica is a cornea, cataract, and refractive surgery consultant in Chikto Mangunkusumo Hospital. She has completed the International Fellowship of Cornea, Cataract, and Refractive Surgery at Chikto Mangunkusumo Hospital, an observation program at the John A. Moran Eye Center in Utah in 2017. Dr. Jessica has also undertaken a fellowship in cornea and external eye disease at the Tilganga Institute of Ophthalmology in Nepal. She's an active member of both INA SCRS and APACRS. Dr. Jessica, the time and place is yours.
Thank you, Dr. Aisyah, for the kind introduction. Assalamualaikum warahmatullahi wabarakatuh. Good morning to all professor, consultants, fellow, and residents. Today, we will have our first lecture by Professor Lloyd Williams. Please allow me to give a brief introduction for him. I think there's no need for introduction, actually, but he is an associate professor in Department of Ophthalmology, Duke University. And then he also the director of Global Ophthalmology and Refractive Surgery of Duke University. And he had the education in the Cornea, Cataract, and Refractive Surgery Fellowship in Wilmer Eye Institute, Johns Hopkins, Baltimore. So please, Dr. Prof. Lloyd Williams, I invite you to present our first lecture today about best practice in anterior lamellar keratoplasty. So actually there's a participant in this room and also in the Zoom. So if you have any question, please just, especially in the participant in the Zoom, you can write in the chat box. And also we have the discussion after the lecture. Please, Prof. Williams, the time is yours.
Sorry, it just takes a moment for everything to fire up. Thank you for having me in Jakarta again. It's great to be here for the second time, and I'm excited about some of the more complex surgeries that we're going to do this time, and also to be doing surgery here in Jakarta for the first time. I've been in Banjarmasin and Jogja doing cornea transplant several times, but I believe this will be the first time where we're actually getting me into the operating room here in Jakarta. Today I'm going to talk about anterior lamellar keratoplasty. There are essentially a couple approaches to that. We're going to focus on deep anterior lamellar keratoplasty, since that's sort of the most useful with regard to restoring vision in patients. But I'm also going to briefly talk about or at least mention the use of cornea tissue for patch grafts and some ways that we can make better use of the corneas that we have, since corneas are in short supply in Indonesia right now. So we're just getting some of the streaming stuff ready. So if you'll just give us a second. So let me just ask the room, how many people in here have done deep anterior lamellar keratoplasty? How many have you done? 5. Okay, that's awesome. With the big bubble technique or one of the manual dissection? Big bubble. What do you think? Hard, easy?
Because most of our case is corneal cicatrix, so big bubble success rate maybe 50%.
Sure. Yeah, that would be my experience in like Sierra Leone as well. Most of the cases are corneal scars, prior perforations. There's a lot of things where the cornea has a lot of posterior pathology or potential prior ruptures and things, which can make the big bubble more difficult. So one of the cases I'm going to present here is not my case. Something that I'm going to work on when I get back to Duke actually is some techniques other than big bubble so that it can help with the cases where there may be already a rupture. When you did the keratoplasties, was it tissue from collected here in Jakarta, or was it brought from international?
Mostly from Nepal.
Okay,
Yeah.
but you did them here, not in Nepal.
Yeah, I did it in this hospital.
Okay. Have you with the local tissue, have you guys done DMEC or separated out and used the tissue for a DOC and a DMEC or anything like that yet?
Since we cannot do DMEC, so mostly for the local tissue we just use 4 PK.
Okay.
Because the quality of local tissue is not so good, because maybe of the transportations and the time from the death and the retrieval of the cornea is not ideal.
Sure. Yeah, obviously, just sort of looking at tissue from around the world and tissue that we get in America, I think death to preservation time is a pretty important number in sort of looking at tissue quality. Maybe a more important number even than endothelial count. Because I find if that number is pretty short, you start out with a tissue that's nice and clear and it seems to get clear fast when you put it in the patient, and those seem to go very well. Whereas the really long death to preservation times, sometimes they'll have a nice endothelial count and then they still don't clear, and at the end you sort of wonder what happened. Was it surgery? Was it the tissue? I'm not sure. So I think we should be up in just a sec. And for those of you who aren't actually in the room and couldn't see that, that was Dr. Farabee that I was talking with there. Ready? Good to go. All right, here we go. Just a brief overview, since there are probably some people on the call or in the room who don't have a long background in corneal transplantation. I know there are others who are pretty skilled. So I'll go through this pretty quick, but just a brief overview. Corneal blindness makes up about 5% of the causes of blindness worldwide. In the United States, a lot of times that's Fuchs dystrophy. Closer to the mic. There we go. And so corneal blindness is about 5% of the blindness in the world. In America, a lot of that is Fuchs dystrophy. There's some corneal scarring. We do get corneal ulcers and traumas. There's also some pseudophakic bullous keratopathy. We don't see a lot of that. And we see corneal transplant, or we see corneal failure at Duke. Probably one of the more common reasons is patients who have glaucoma tubes or who've had other complex eye surgeries that over time, multiple surgeries leading to endothelial failure. This is a distribution of blindness around the world. You can see that Indonesia still ranks as one of the countries with higher rates of blindness, despite the fact that there are fantastic centers like this one here in Jakarta and the one in Yogyakarta. There are also areas sort of more out in some of the other islands where there may not be a lot of access to eye care. And I know a lot's being done, but in particular with cornea, we think that there is somewhere between 100,000 and 200,000 transplants waiting to be done on patients who have one or both eyes with corneal blindness. This is an example of a patient in Sierra Leone with corneal blindness due to scarring from prior infection. In Africa, one of the major causes that we see is untreated corneal ulcers. We also see pseudophakic bullous keratopathy from poor cataract surgery. And we also primarily see chemical burns. Some of the cultural practices in terms of treating conjunctivitis or other eye redness or things like that, there are some plants that traditional healers will put on the eye that can result in chemical burns. And those can actually be really quite difficult to treat. This is bringing cornea tissue to Sierra Leone. As you know, we also bring cornea tissue to Indonesia sometimes. And this time, I do apologize. We didn't bring as many tissues as we would like or usually would want to, but there's been a little bit of a decrease in supply in the United States for reasons I'm not entirely sure of. And so we brought what we could. And we'll try to think about ways that we can make the most use of the tissue. There are some interesting things that I've seen being done in India and Nepal, and it'll be exciting to talk about how those could be applied in the circumstances here, such as doing 2 small 6-millimeter grafts out of one cornea, or using a cornea for DMEC and DALK and things like that. As Dr. Rena said, we work to teach cornea transplantation through the Duke Global Ophthalmology Program around the world. We've now done 106 transplants in Sierra Leone, including this patient, who was the first cornea transplant in Sierra Leone history. You can see the graft right here. And I think of all the patients, her and one of the patients from Indonesia recently in Banjarmasin are 2 that just really show me the incredible importance of access to corneal transplantation. This woman went blind when she was 14 years old. You can see that her right eye is tisical and completely no light perception. She was light perception only in her left eye. And from age 14 to age 43, she was light perception only. She survived the civil war in Sierra Leone. And when her town was attacked, she picked up her babies and ran away, not knowing whether she was running towards the people with the guns or away or anything, or whether she was going to run into a tree. And at age 43, we were able to do, she was the first cornea transplant in Sierra Leone. And post-op day 3, she was, let me convert it into meters, about 624. And she went out and saw her children and her husband for the first time. And so that was a pretty amazing moment. We had a patient in Indonesia recently, age 23, lost both hands and both eyes in an explosion. And we were able to do a cornea transplant and restore his vision after being 8 years light perception only. So there's a lot of patients in the world waiting for this who have some pretty devastating circumstances. That young man with no hands and no vision had tried to commit suicide a couple of times. Fortunately, had not succeeded. And just sitting with him and his family when he got to see again for the first time was a pretty emotional moment for everyone. So to hoping that will happen more and more. There are about 185,000 cornea transplants per year worldwide, and about 284 corneas procured. Most of those corneas are in the United States and India. Over time, hopefully Indonesia will become one of the places where many of those transplants are procured as well. And I know that people in this room have done really amazing work and forwarding the eye banking in Indonesia, and hopefully that is really going to lead to a big change in treating corneal diseases here. About 60% of the transplants worldwide are penetrating keratoplasty. This is just a short slide about the different types of keratoplasty. Penetrating is a full thickness transplant. Anterior lamellar and deep anterior lamellar are transplants of the anterior cornea only, leaving the patient's endothelium and descemes. DSEC is a posterior transplant, which contains some stromal tissue, and DMEC is a posterior transplant containing no stromal tissue. In the United States, PK has been falling off in terms of its overall usage. This is mainly due to the development of DSEC and DMEC, and also due to the development of cross-linking, which has reduced the number of transplants needed for keratoconus quite a lot, cross-linking and scleral contact lenses. You'll see here, DALK is this green line here, and the DALK rates are pretty low. They were going up a little bit, and then they've sort of fallen off in the United States. I think the main reason for this is that DALK is technically more challenging than PK, and because one of the primary indications for DALK is keratoconus, because those patients have an otherwise healthy eye except for the disease in the stroma. And so
Excuse me, Prof. Williams, so sorry, here. So I think the file in the Zoom is corrupted. So may we copy it again one more time from your laptop so the audience in the Zoom can also see the presentation? So
Okay.
sorry.
Yeah, no problem. Actually, let me give you a drive that I have over here so that we don't have to copy. You can take it off my drive.
Just right to the stickers.
Where would we be without technical difficulties, right? But this slide actually brings up an interesting thing about DALK in that, you know, I think if you were going to look and say, where are the the most DALK surgeons, or maybe the best DALK surgeons in the world. It might be India right now, or Nepal, since they have less tissue and they sort of have a drive to figure out how to make more use out of one tissue. In the United States, it's actually illegal for us to use a tissue for more than one patient. So there's no value in us trying to figure out, okay, how do I do a DALK and a DMAC with this patient? Or with this one tissue, because we're not allowed to anyway. And because we have excess tissue, it hasn't forced us to learn how to be very careful with not wasting tissue or not losing something. So if we do a DALK, we'll strip off the decimes and then discard it, which is kind of a shame. So you know, some of the centers in India where they can use tissue from more than one patient, or where they may not have as much tissue, I think they've really had a drive to master DALK and do a lot of them. The other thing I think that happens in America is we have a lot of corneal transplant surgeons, so it kind of gets divided out among lots of different surgeons. If you have less cornea transplant surgeons in more cases, then each surgeon ends up doing a lot more cases. And as you know, that's the key to getting really good at some of these things, is doing it over and over and over again. All right, so we're back on track. Just a picture of a penetrating keratoplasty, pretty standard, usually 16 interrupted sutures. Some people do a running suture or a double running suture. That's a bit less common in the United States, and there are reasons for each. That same kind of suturing is also what you would do for DALK. And so for DALK, you can do running sutures or interrupted sutures. The advantage of interrupted sutures is if one gets loose, breaks, or if you have irregular astigmatism being caused by the sutures, you can remove them individually, whereas the running suture has to be removed all at once. So if the running suture breaks, then you have to remove the entire suture. On the other hand, unlike PK, if you're doing DALK, you haven't entered the anterior chamber, so there's less of an issue of the actual stability or strength of the eye. And so you can take sutures out earlier if you needed to, without the risk of the eye perforating. And so some example cases of penetrating keratoplasty for scarring and for prior ulcer. So onto the sort of main portion of the talk. Deep anterior lamellar keratoplasty is a stromal only procedure where the patient maintains their endothelium. It's sutured in place, just like you would suture a penetrating keratoplasty. The use for it is corneal scarring, other anterior corneal problems like the corneal dystrophies, like the stromal dystrophies, macular, granular, and lattice. It's generally not indicated for perforation, although there are definitely groups. In particular, there's a group in India that presented a lot at ASCRS this past year with techniques where they are doing a very deep manual dissection, but leaving some stroma behind, so that despite the fact that there is a defect in decimes, they're able to do deep anterior lamellar keratoplasty. And they were also showing DALK for prior corneal eye drops, which was actually pretty amazing to me. I would have thought, you know, the definition of eye drops is that you have a large rupture in decimes. So the fact that they were getting really quite nice results with prior corneal eye drops and manual dissected deep anterior lamellar keratoplasty was something I thought was pretty amazing. It's technically challenging getting the big bubble. This is the Anwar big bubble technique. Is tricky. And then there are type 1, type 2, and type 3 bubbles. We'll talk about that a little bit. If you get a type 2 bubble, then that can also be pretty delicate in terms of managing the surgery. The good sides of DALK, lower risk of rejection. You can't get endothelial rejection. That's great. And lower risk of expulsive hemorrhage during surgery or expulsion of lens contents or other intraocular contents, which actually can be quite useful in terms of surgery. Long term, there hasn't been a clear, I haven't seen any studies that absolutely clearly define that PK versus DOLC, that there's a significant difference in sort of long-term vision or long-term graft survival, despite the fact that penetrating keratoplasty definitely has less long-term endothelial cell survival. So in DOLC, you remove the anterior stroma. You can see here in this picture that they've begun the process and are going to remove those leaflets. And the results look actually quite similar to a penetrating keratoplasty. So we're going to go through a couple DOLC videos. This is one from the Moran Eye Center and Mark Mifflin. Step one is to do a vacuum tree find, usually about 2/3 depth or roughly 300 microns. Using a pentacam or something like that to actually know what the corneal thickness is all the way around can be quite helpful in terms of avoiding perforation with the microkeratome. A lot of people will remove the anterior cornea, and there's some debate as to when to add bubbles into the anterior chamber. So we'll go back to that just real quick. And when to do the side port incision. So he's removed the anterior, probably 2/3, and then made a side port incision and is going to place some bubbles in the anterior chamber. Those bubbles can be helpful for a couple of reasons. One, they can assist in knowing how deep you are when you're inserting the cannula. And two, when you get a big bubble, it will push the bubbles out to the side of the cornea. And so then you can be sure that you got the big bubble that you were intending. The disadvantage of making the side port incision at this stage is you can end up with a little bit low pressure inside the eye, and that can actually make it a little bit more difficult to insert the needle or the cannula into the stroma to get the right depth. So there's some variations in how people approach that. Now they just inserted adult cannula and some air. Some people use a needle, some people use adult cannula, some people use a needle and then adult cannula. Here we're putting some viscoelastic on the cornea. This has been shown to be helpful in making the brave slash. So once you push the Descemet's membrane back with the bubble, you still haven't perforated the stroma. And so you make a quick slash to perforate the stroma and hope that the Descemet's membrane doesn't pop up fast enough that while your blade is in there, you also slash the Descemet's membrane. So putting viscoelastic on the surface of the eye can slow the air egress from that bubble and give you a little bit more time to remove this. There's also been some techniques presented on how to do this bluntly, and we can mention those as well. So there's the slash. Didn't get it the first time, got it the second time. By inserting viscoelastic into the space, and you can see that the bubble has now moved back into the center. By putting viscoelastic in, the bubbles move out to the edge, and then we can use blunt-ended DOLC scissors to cut 4 leaflets, and then we'll cut around the periphery, and we have a nice bed to suture in the transplant. Here, we're preparing the tissue and stripping Descemet's membrane. You could strip Descemet's. You can see he's stripping it in pieces and not sort of being careful to preserve it. But you could strip this the same way that you would if you were preparing DMEC tissue and then preserve that tissue. Punching the cornea to size. I same size my DOLC. I don't same size my penetrating keratoplasty. I usually oversize by a half. Some people oversize by a quarter, but usually the penetrating keratoplasty is oversized and the DOLC is same sized. And that's the DOLC surgery is done at the Moran Eye Center. So briefly, big bubble, type 1, type 2, type 3. The type 1 bubble contains Dua's layer or the pre-Descemet's layer and the Descemet's membrane and endothelium. This is the preferred bubble because it's got quite a bit more strength than the type 2 bubble, which is Decimase membrane only, and the endothelium. And a type 3 bubble is a combination bubble where you have a little bit of both. The type 2 bubble can still be used in DOLC. It just requires a much more careful dissection. And I'll show an example where I believe I had a type 2 bubble and then made a small perforation during the dissection. So these are some of my cases. So we tree-fined to about 300, 350 microns, dissected off the anterior. This is a needle. You want to go bevel down so that the tip of the needle doesn't stick and catch and dive into the anterior chamber. I made a needle pathway, and now I'm inserting a DOLC cannula. And sorry about the focus here. My former fellows and current fellow are going to hate this, but I wonder if a fellow was involved here since it's out of focus. Those of you who have presbyopia understand how that goes. So then a slow air injection, viscoelastic on the cornea, the Brave slash, and remove the corneal tissue. I'll just show the last step here. And then suture. This is another DOLC. This is actually other eye, same patient. And in this case, I'm doing, instead of a needle, which is a sharp dissection, I'm doing a blunt dissection with a DOLC cannula. And we're inserting the air later in the stage. And then dissecting off the corneal tissue. So I've tried a variety of ways, sort of looking for what's easiest for me. You know, if you look at the DOLC surgeons around the world, there's a lot of variety in how people do things. And you'll see, you'll see somebody say, I always do this, and then you'll see somebody say, I never do this. And so on some level, you have to kind of try and see what works for you. This is an example of how you can see the bubble here. And this is an example of how you can actually rupture even in this stage right there. Now, we'll just pause there. Ruptures like that aren't the worst. Well, they're not ideal, but it's not the end of the world. So this patient, we still successfully did a DOLC. I avoided that area of rupture with the scissors and came in and dissected off all of the rest of it. Came back, cleaned up that area. We did a DOLC anyway, and it was still successful. So small ruptures can definitely be preserved. If they occur early, it's a little bit harder to deal with, but even a small rupture that occurs during the formation of the big bubble you can then go and do a manual dissection and still get a good result. So these are some other surgeons, and this is a different approach. So this is in this case, we're doing a blunt dissection around the periphery and doing a spiral. So this is what you might do if you wanted to manually dissect the entire DOLC. So you start with the tree-fine, get a little bit of a tunnel, and then do a blunt dissection and keep going in a circle. So he's gone around once. Now he's going to go around a second time, and this time he's aiming for a much deeper plane. And as we keep cutting and go around, and you can go around as many times as you need until you find a very nice deep plane that you're looking for. Once you're confident that you're deep enough, you can separate all the tissue from the periphery and then peel this off, and it will generally rupture right about at Dua's layer. And so a nice wide piece of tissue and peeling. And there you have eye bed prepared for DULC. And in the center, this center area is quite thin, and you'll get a good visual outcome. And that's called grip and peel. The scissors or the devices that people use, Fogla has worked on this some, and you can use his dissector to start or others, or and then these are the scissors that were being used in that case. There are other similar ones. So that's the groove and peel. Some pearls, and these come from Dr. Soberman at Wilmer. Partial thickness trephination, use the dissector to form a deep surgical plane, and then the scissors to establish that plane around. The first time you go around, you're going to be a little bit superficial. The second time around, you're going to try to achieve the full thickness depth that you want down to Dua's layer, and then peel the tissue with a very large base to try to distribute the forces so you're not pulling in just one spot. And some other tips for DULC, getting the number one difficulty in DULC is getting the cannula at the appropriate depth or the needle at the appropriate depth. If you're somewhere around 60 to 80 microns, you can pretty reliably get a good big bubble. If you're at 150 microns or not nearly as deep, you won't get a good big bubble, and you'll get aeration of the corneal tissue. And then when that happens, it can actually be really quite difficult to see to take another attempt at getting a good big bubble. And obviously, if you go into the anterior chamber, then you've perforated and you have to figure out how to complete your case with a manual dissection. These tips, again, like I said, everybody has different ways, but if you're doing it for keratoconus, doing a larger diameter graft can be really useful, because the depth or the thickness of the cornea varies more the more central you are in keratoconus. So if you can be out in the periphery where it's a more uniform thickness, that can help you with your original tree fine. There are some great technical tools if you have access to them. One of them is intraoperative OCT that can help you evaluate if your needle depth is appropriate, and so that you can go deeper if you need to, or stop going deeper if you need to stop going deeper, in order to get the right depth for attempting the big bubble. You can also use femto assisted, so you can create the channel with a femtosecond laser, and then all you have to do is put a cannula in it, and there you can program the depth pretty reliably. Obviously, the femtosecond laser doesn't shoot through opaque cornea, so it depends on exactly what you're treating, but particularly in keratoconus, this could be really useful. You can use a red reflex guide. So this is somebody who when you press down and push forward with this cannula, if you're at the correct depth, the wrinkle will be right at the tip of the cannula. If you're not, the wrinkle will be in front, and you'll see a gap between the two. And I'll show a picture of the Lamellar technique doing that with air bubble as well. If you get a type 2 bubble, you want to carefully dissect the periphery like I showed. And also, in terms of your suturing, one small difference between DULC and PK is when you suture, you want to go a little shallower on the donor and 90% depth on the host, so that it actually pulls the donor down onto the host, so that you get Descemet's membrane attaching nicely to the donor tissue, because it is actually possible, and I'll actually show some pictures of this too. It's possible to end up with a double anterior or a double anterior chamber, so that where you don't get Descemet's actually sticking to the host stroma. These are some of Dr. Fogla's tips. Practice feeling what the resistance is when you're putting a blunt cannula, And I find this to be quite helpful too. When you get a adult cannula into the layer between stroma and Dua's layer, it actually feels easier to advance. If you're directly in stroma, you have to push pretty hard to get that cannula to advance through stroma. So as you feel, you should be able to feel when you get a better plane with the blunt cannula. Fogla uses the reflection of the air bubble in the anterior chamber. I'll show a picture of that next. We talked about the wrinkles in the posterior layer. He does do pachymetry to know how deep to cut. And so I recommend using ultrasound pachymetry or Pentacam if you have it to know, like, does this person have a 400 micron thick posterior or peripheral cornea, or do they have a 700 micron thick peripheral cornea? That'll help you know how deep to trephine. Intraoperative OCT is great if you have it, and femtosecond is great if you have access to that. We do have femtosecond lasers, but because of how the OR is set up, I have not done a femtosecond assisted DALT. So here's the Mellis technique of using, you can see that there's an air bubble in the anterior chamber, and here he's not very close to the right depth. Here he's closer to the right depth, and here he's at the depth where the remaining stroma is very thin. And so that's another technique that can be used to guide you for depth. So once you have everything set, this is Dr. Fogla's video on how to prepare Descemet's membrane and for DMEC, but it's also exactly what you need to do when you're preparing for doing a DALK, even if you aren't going to save the tissue. The only difference is, you know, for example, you wouldn't stamp it or something if you weren't going to preserve the tissue. But here he's done a trephine, used the trephine to cut just into the layer and is going around and just separating the edge. And he marked it in advance so he'd be able to find it. The marking is with the usual ink that we have. And then it will stain with trypan at the end. Then using a wide forceps that's blunt, not sharp, so not like 0.12s or something, you can gently peel this layer off. And by doing that, you can actually use this for to do a DMEC later. Descemet's tissue is pretty delicate for those of you who have worked with it. So you have to be quite careful not to tear this. Also, he's being very careful only to grab at the edges, as you can see. If you make a big grab right in the middle, you're going to damage those endothelial cells. So he's trying to make sure that if there is any endothelial damage, it's only occurring right at the periphery. And that's trypan blue. The reason we use trypan blue and DMEC, and Dr. Song, I'll talk about this a little more tomorrow, is just so that you can see the graft. It's very hard to see in the anterior chamber if you haven't stained it. He didn't show making a mark on it there, but it's also quite helpful to make a mark. We use a S stamp. Some people use an F. Whatever letter you want, it has to be something that enables you to tell right side up from upside down. So, you know, not like an I or a T. And then that graft can be inserted into a variety of inserters for the anterior chamber. This is an example of one of the things that you'd like to try to avoid in DALK. You can see here, this is the patient's endothelium, and this is the graft. This is one of my patients, and surprisingly, the cornea is not swollen and is very clear in this patient. So we've just been watching this. I'm not sure how the tissue stayed clear when the endothelium is down here, but And then here you can see the edge between the DOLC and the patient. But what do you do if you see something like this? This is another example where the endothelium isn't attached. You can put an air bubble in just like you would in DSEC or DMEC and use the air bubble to press the endothelium up against the cornea. And here you can see that the cornea is actually quite thick. And so after we put an air bubble in here, the patient positioned for 2 days, the cornea cleared and the endothelium stopped. So DOLC versus PK. PK technically easier, longer rejection treatment necessary. I usually keep people on drops at least once a day forever. More endothelial loss and more rapid endothelial loss. Up to 30% rejection, depending on why you're doing the PK, and similar visual outcomes and long-term survival. And I've actually seen PKs that were 50 years old, that were placed 50 years ago that are still clear. DOLC has reduced risk of expulsion. That's great, particularly in Sierra Leone, where I'm often operating on 22-year-olds who are wide awake, no anesthesiologist present. They're very tense. There can be a lot of posterior pressure. And so not entering the eye at all helps make sure you don't lose a lens or worse. Less post-operative steroid. Some people taper off steroids within the first 3 to 6 months even. Reduced endothelial loss, low rejection rates. The vision recovery may be a little bit longer, and DOLC may not improve long-term survival, but it does offer, in a place where tissue is at a premium, it offers the ability to do at least 2 surgeries with 1 tissue. This is just a post-op thing. We're just going to skip through that for time. And then one last case, just as a, speaking of anterior lamellar keratoplasty, here's a patient who, we'll go back just so we can get a good look at that. Here's a patient who has a peripheral perforation. And so we're going to do a anterior lamellar keratoplasty, but in this case, in the periphery, only as a patch graft. I think you recognize this eye, right, Dr. Song? She does. Was this your first case at Duke? Yeah, this might have been your first actual holding instruments in the hand case. When I do cases like this, a lot of times some epithelium has grown over the area. So you can see how the eye looks pretty bloody right now. I take off all the epithelium so I'm not sewing epithelium into the eye. And you can see that the defect is really sort of an odd shape. And a lot of times I'll try to clean up these edges so that I have something nice to sew to. So that's what I'm doing here, is I'm just cleaning up some of the tissue. And we've scraped off all the epithelium. What I like to do then is take the graft and sit it over the defect. And since you can see through the graft, you can then mark out the defect pretty exactly, and then use corneal scissors to cut the tissue. Corneal tissue is actually quite difficult to cut like this. So it's nice if you have 1 extra hand or 2 to keep the tissue under tension so that the scissors make it a lot easier to cut. It's actually quite difficult to do that just alone. And then we sew the tissue in. Again, I like to prepare this edge so that when you sew it in, it sits pretty flush on the host. And this patient did actually quite well. You can get defects like this from ulcers, but you can also get them from peripheral ulcerative keratitis and other non-infectious causes. Let's see if we can just see that at the end. And so that's the almost finished. We just had 1 stitch left here. But you can see how these edges line up actually pretty nicely. Usually I'll trim this edge a little bit too, so it doesn't stick up too much. And you can see that we've resected the conjunctiva a little bit because this was a patient with peripheral ulcerative keratitis. And one thing, Dr. Rennie in Jokja has worked with me on this in terms of the tissue that we bring is we've been storing, once we use a tissue, we've been storing the tissue or the scleral rim and what's left of the cornea tissue that we didn't use in the case. We've been storing those in 95% glycerol. This is the recipe. It's 95% glycerol or 100% glycerol with 5 drops of moxifloxacin. And that allows you to preserve a cornea for up to about 5 years. And that doesn't save the endothelium, and it doesn't preserve all of the stromal architecture. So you can't use these for doing optical quality grafts, but they're really great for peripheral ulcerative keratitis patch grafts of any kind. And so you can do a patch graft on a patient who has a perforation with this tissue and then come back and do a graft for vision restoration later because you've saved the eye. And so we've started storing our tissues in Sierra Leone this way too, after transplant. And just a couple of other things. These are sort of my own projects. Teaching fellows and people around the world. Common reasons for graft failure: broken sutures or things irritating the eye. You can see a suture here sticking out. If you leave this, it'll turn into rejection or infection nearly every time. So every time I see a transplant patient, I'm always looking, are there any broken sutures? Are there little tails sticking out? Is the end of the stitch sticking out? Is there anything that's going to irritate this eye and cause it to fail? And so my fellows have definitely suffered through clinic with me, where they come out of a room and I come in and I'm like, what did you miss? And it'll be like a real old suture that's hard to see, maybe up in the corner, that's sticking out a little bit. The other common reason for graft failure is patients don't use their drops, either because they didn't understand or because they ran out or the pharmacy didn't give them some. And so one of the things I do is, we go over and over what the patients need to do. We talk about how they're never going to be off drops ever. Don't ever stop this drop, the one with the pink top, or whatever the color is here. And I usually give patients my phone number so that if they go to the pharmacy, they don't get the drop, then they'll call me or text me and say, hey, I went to the pharmacy, I couldn't get my drops, what do I do? And then we help them get them. Because I'd rather find out that way than find out a month and a half later when they come in because they can't see. These are some helpful links. Duke has some manuals of ophthalmic surgery online. Eversight Vision, this website here has some really great lectures with Dr. Fogla and others on manual DALK techniques. So if you're really looking to learn more about that, this would be a great research. morancore.utah.edu. I helped the Moran Eye Center build that. You've been at the Moran Eye Center, so you know how great the staff is there, and so the lectures there are really great. And you can reach out to me anytime at lloyd.williams@duke.edu. Questions?
Thank you so much, Prof. Williams, for the very insightful lectures. Is there any question in the auditorium?
Hello. Yes, thank you. I would like to thank you for the presentation, Prof. Lloyd. I'm Putri from stage 2 of residency. Thank you, doctor. I would like to ask, what are the main causes of poor vision after good operation of DALK? And secondly, how do you monitor long-term endothelial health after DALK? And is there evidence that it better preserves endothelial cells compared to PK?
Yes. I'll go in backwards order. Yes, there is evidence that it better preserves endothelial cells compared to BK, quite a lot. What are the causes of vision loss after DALK? You can still get rejection, even though rejection is less because you can't get endothelial rejection. There's still stromal rejection. And patients also can get infections from loose sutures. There can be, or or from other causes. There can be, if you remove sutures too soon, you can get gaping at the intersections and have to go back and clean that up. If you're doing, say, a manual dissection and you don't get deep enough, you can get interface haze at the stroma level that can reduce vision. Irregular astigmatism from the suturing is probably the primary cause of decreased vision, in that all patients who have PK or DALT will have some astigmatism at some point from the suturing. And theoretically, if your suturing is perfect, that's pretty low, but that it's definitely a big factor in people's vision after DALT and PK. And most people will get their best vision with a scleral contact or a rigid gas permeable contact rather than just straight glasses. Although occasionally you'll have a case that goes really great, and I have one person who's 20/20 uncorrected after PK, but that certainly isn't the norm in any way. And then the middle question was
The endothelial health after DALT.
Yeah, so the endothelial health, if you do the surgery well, it should be great.
Yeah. Dr. Williams, it's wonderful to have you back with us.
Yeah, it's good to
I'm
see you.
Hanifa, cornea, cataract, and refractive surgery subspecialty trainee here. I'd like to ask you two things. First, what are your best tips for achieving successful big bubble formation in case with the new neovascularization and also scarring? And second, what would you recommend as the most effective way to reach to surgeon's training?
So best way to do with scarring, and what's the best way to train? Is that right?
Yes.
So I think the best way to train is when you're doing PKs to attempt a DALK anyway. So when you cut down, try a big bubble. Even if you're going to do a PK, try to make a big bubble. If you're successful, great, you learned. If you're not successful, you still learned, and you then do the PK anyway. Because attempting the big bubble isn't going to harm the patient or cause any problems with the PK itself. And so one of the ways that surgeons in America can get better and better at this, we do hundreds of PKs a year at Duke and probably tens of DALTs. And so if we take all those PK cases and practice DALT, that gives us a lot more experience than we would otherwise get. In the cases with scarring and cicatricial changes and neovascularization, I do think that the techniques like grip and peel actually make a lot of sense. Now, if the scarring is straight through the middle, you may not be able to do the peel without risking damage, and you may have to continue that dissection all the way through the middle. But the manual dissection techniques where you're definitely leaving some stroma, that stroma does heal in the scarring. And so if the scarring is not in the visual axis or all the way, absolutely 100% all the way through, and you have some clear stroma in that area, if you leave less than 100 microns of stroma behind, the groups in Italy have shown that doesn't seem to affect final visual outcome. And so I would say manual dissection is the best way to handle that rather than big bubble. Big bubble puts a lot of pressure on the scarred area and can definitely break it open.
It's more safe with manual dissection.
Yeah.
For that case. Thank you very much.
Maybe I want to ask if you do a manual dissection, and then how you can know that you are deep enough if you don't have any pachymetry intraoperatively?
Yeah, you could theoretically bring an ultrasound pachymeter in. Of course, you'd have to have it sterile, but the best way to tell is you'll see as you dissect deeper and deeper, the underlying cornea becomes clearer and clearer. So when it looks really clear, then you're far enough. If it's still hazy or you have sort of the strands of stroma and stuff sitting there that you can see, then you need to go deeper. but yeah, you definitely can see as you dissect down, it'll get clearer and clearer and clearer. And when you have that sort of final nice clear sheen, there still can be a little bit of stroma on that, but when it's nice and clear, then you're good.
Is there any other question from the audience?
Thank you for the wonderful presentation. My name is Dianisa. I'm in my third year of residency. I have 3 questions for you. First of all, I wanted to ask, is it common in your center to use one donor cornea for multiple patients?
Never.
Never? Oh,
It's illegal
oh.
in
Okay.
America.
But like in situations where you're in Sierra Leone or in other places, would it
Ye-
be an option?
It is an option.
Oh.
Yes. And I think in India, I've seen some nice presentations where they actually cut like 2 pieces out of one cornea or took a peripheral patch and a central PK and so yeah, there's definitely quite a few places in the world where they do use more than one patient for a single cornea.
Probably for emergency cases.
But even in America, if it were an emergency or anything, we still can't do it. Like it's just not allowed.
Okay, and also I've been reading about glycerol preserved corneas, and
Mhm.
you had a slide about it. I wanted to ask, in your center, what temperature is used to store these GPC corneas, first of all? And second of all, you mentioned the use of moxifloxacin as the antibiotic. I was wondering, is there a particular reason why moxifloxacin? Because from what I read, Optisol usually uses gentamicin and streptomycin.
Yeah. So I used moxifloxacin because it's readily available and very broad spectrum. And in the recipes I had been reading, that was one of the things they used. Gentamicin and streptomycin is something, when I was in Sierra Leone and we were first starting to store glycerol, I don't even know where I would find streptomycin. So the moxifloxacin works well and is cheap and easy to find. And in addition, most of the antimicrobial properties of the storage are just the glycerol. Like microbes really can't grow in glycerol. In terms of what was your second question?
The temperature.
The
for
temperature.
GPCs.
I usually stick them in the refrigerator.
So right around 4
Yeah.
degrees Celsius. Okay. So is it? Oh, that's it. Thank you.
Oh no, it's fine. You can ask more. Yeah.
Is there one question? Maybe one last question. So from the lecture, I learned that you can still try to do dark even there is a microperforations happening. So what is the cue that the dark is not going to be successful and will have like complication post-operatively like double chamber? So we have to switch to picking or just do dark and give air tamponade at the end. So what will be the strategy?
Yeah, as you've seen, even if you haven't done DMEC, you certainly have seen videos of DMEC, and so you see how, or you've done a cataract surgery where you can see like the Descemet's membrane maybe has a little tear and is flopping around, and so as you know, Descemet's will tend to curl up on itself, and so if you get a tear in Descemet's that's large enough, especially early on in the procedure, it's very hard to then remove the stroma from the Descemet's and pre-Descemet's without extending that tear. So what I would say, macro perforations, you end up doing PK. Micro perforations, you can continue with DALT. But how do you know, like, what's the line between micro and macro perforation? It just kind of depends. In my own experience, if I know that I have a perforation like that one I showed where the bubble came out of the anterior chamber, then what I'll do is I'll just try and I'll try to finish the dissection. If I finish the dissection and there's obviously Descemet's or Descemet's and pre-Descemet's sitting basically covering everything, then I'll continue on with the DALT. If it looks like there's a big chunk missing or a big tear that's rolled up on itself, then I'll just cut the rest of it off. So in my own hands, basically, I just keep trying the dock until, until I've clearly messed it up to the point that it's not salvageable. In terms of avoiding, so then how do you avoid getting a double chamber? Make sure that there's no viscoelastic sitting on the Descemet's membrane when you go to sew the dock down. And if you have a perforation or something that you're concerned about, start by putting a bubble in the anterior chamber and have the patient positioned just from the beginning to press everything up so that they don't get fluid and stuff in that gap.
Thank you so much, Prof. Williams. So I think we can do the next sessions this morning. So thank you so much for the lecture. So for the next session, we will have a case presentation for the case that we're going to do at the OT today. So the residents will present the case. So actually we prepare 5 cases today. So there will be 2 DALT and 2 DMAC that we plan from the same donor, and then 1 PK. Please, Dr. Paulo.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, professors, doctors, and fellow residents. My name is Alwan, ophthalmology resident from the Infection and Immunology Division. Today, I was given the chance to present 1 case regarding complex corneal transplant. So here I present the first patient who is scheduled for penetrating keratoplasty of the left eye today. A male, 33 years old, had a long-standing history of untreated recurrent eye infection over 10 years, which led to progressive visual decline in both eyes. In 2019, after being diagnosed with corneal thinning, he underwent a corneal transplant in the left eye with temporary improvement. However, due to his occupation in a dusty construction environment, recurrent issues were likely aggravated. Since 2023, his vision has again become blurry in both eyes, although there is no associated pain or discharge. With past ocular history is as follows. In 2017, the patient experienced progressive blurry vision in both eyes. The right eye lost light perception completely. He only sought treatment at primary health center and never consulted an ophthalmologist for proper diagnosis and management. Although he continued using eye drops, they were no longer effective. In 2018, he sought treatment at Tangerang Hospital, where cataract surgery was performed. He was then informed that his cornea had become thin and required a transplant. So he was referred to RSCM for further evaluation and management. In 2019, the patient underwent PKP in the left eye at RSCM with a corneal donor. After the surgery, his vision has improved and he was able to return to work. However, his work environment involved heavy dust exposure, which may contribute to recurrent ocular issues. So then in 2023, the patient experienced graft rejection in the left eye, resulting in blurred vision in both eyes again. But notably, there is no pain or itching during that time. And on March 7, 2025, the patient underwent a re-PKP of the left eye due to graft failure. Up until the present, the patient only complaint remains blurriness with no associated pain or eye redness, and also no discharge. So to summarize the intervention for the left eye, in 2018, the patient had phaco-IOL of the left eye, which was performed at the previous hospital. And also the patient had undergone PKP, which was first performed in 2019. And then in 2025, in the July, patient had undergone a re-PKP due to graft failure. So this slide shows the clinical of the patient's left eye 1 week after repeat PKP. And on visual acuity was hand movement, which was the same as before surgery, and the intraocular pressure was 4. corneal grafts appears cloudy and edematous with positive fluorescent staining. The graph measures approximately 8 by 6.5 millimeters. Compared to no infiltrate was seen, 16 nylon sutures are present, arranged radially and intact. There is evidence of deep neovascularization, and saddle test is negative with both with and without pressure. And anterior chamber was centrally deep with mild sulci and flare, and inferior coagulum was present. There is no hypopyon. And other posterior structures are difficult to visualize due to cloudy cornea. And these are clinical findings of the left eye 1 month after the re-PKP with the same visual acuity, and intraocular pressure is within normal limits. And as we can see, the corneal examination reveals the graft appears cloudy and edematous with positive fluorescent staining. And also we can see that deep neovascularization is present, and saddle test was negative with and without pressure. So these are the diagnosis of these patients with post-re-PKP of the left eye due to graft failure, and also history of corneal graft in 2019, history of graft rejection in 2023, and history of viral keratitis of the left eye, pseudophakia of left eye, and also absolute painless glaucoma of the right eye. Current treatment regimen is levofloxacin hourly of the left eye, chloramphenicol for the left eye, eye ointment, and also artificial tears. The patient also was given methylprednisolone 2 times 8 milligram per orally with omeprazole, mefenamic acid, and vitamins. This image show the anterior segment OCT of the left eye. It was taken at 11 of August 2025. It demonstrate corneal graft with increased thickness and also edema, with the corneal thickness measuring 291 micrometer. This anterior segment consistent with the post-operative findings and graft condition which was previously shown. And for the discussion, here are the several points that can be discussed for this patient. Firstly, what strategies can be implemented to prevent recurrent graft failure in this patient? Secondly, what is the role of systemic and topical immunosuppression in reducing the risk of graft rejection in this case? And lastly, what supportive therapies could improve graft longevity? Thank you.
So the first patient is the one eye patient with the history of the failed graft. We plan to perform the surgery today for the PK surgery. Is there any input for this case, maybe from doctors? I think it's already had oral immunosuppressive, right? Methylprednisolone.
Has the patient had a tarsorrhaphy at any point?
So the patient had never no therapy procedure before.
Okay. Does the patient have corneal sensation?
From the last examination, corneal sensation was decreased, but the patient still felt corneal sensation from the graph.
Okay. Do you have access to recombinant nerve growth factor or any of the medications to treat neurotrophic keratitis?
Currently, we do not have that regimen of treatment in RSGM.
Okay. And you mentioned a history of viral keratitis. Has the patient been treated with acyclovir or valacyclovir?
Yes, the patient had already finished his treatment of acyclovir, and it was done in 2024. So,
okay. But no new treatment associated with this transplant?
So from the last examination, there were no current antiviral regimen for this patient.
Okay. What do you think of the limbal stem cells? just from your examination? Do you think that the patient has adequate limbal stem cells or no, or? And on the other eye, do they have limbal stem cells?
What was the last question, Professor?
What does the other eye look like? Are there good limbal stem cells in the other eye?
There I had already no light perception, so the limbal stem cell was not quite good also.
You can have perfect limbal stem cells and also no light perception from glaucoma. So the reason I ask is looking at how the epithelium is healed, it seems that the limbal stem cells, at least inferiorly, may not be very great because you're not seeing epithelium come from inferior up to cover the graft. All of the epithelium is at the top. So you said the other eye is blind from glaucoma. If the cornea is mostly okay, you could actually use, you could even use that cornea and transplant the patient's own cornea from right eye to left eye. And you could also use limbal stem cells from the right eye and put those on the left eye, and you may get a better outcome. Now, sometimes both eyes are bad on the surface, and so then you're stuck. But if one eye is totally blind from processes occurring in the eye, and the other eye is blind from processes occurring on the eye, like cornea, you can actually switch the corneas, and sometimes that yields a result that works really quite well because there's no rejection because the cornea is entirely the patient's. And if you need limbal stem cells, you can transplant them without having to worry about systemic immune modulation. So do we have a picture of the other eye?
I'm sorry, we do not have the picture of the fellow eye.
Okay, we'll see the patient today. Great. So that's kind of what I'm thinking might be the way to approach this. And I definitely have had some very, very successful transplants where we've saved eyes in a patient by either taking a small bit of limbal stem cells from a good eye on the other side, or taking quite a bit of limbal stem cells from an eye that is no light perception and moving those to, so we're saying, okay, we're going to take both eyes and we're going to put them together into one good eye and then one really, really bad eye. And so sometimes that can be actually be a really great way of doing things. And I have definitely successfully switched corneas on patients who have glaucoma in one eye and bad nerve or bad retina, but good cornea. And on the other side, bad cornea, but good nerve, and then just switch to the corneas. You can do them together if you have some type of temporary temporary keratoprosthesis, or if you, so in America, again, we have an embarrassing riches of corneas. So you can take the cornea off the bad eye, put a new cornea on that one, and then while that and leave that one sitting in BSS or something, and then sew that onto the good eye. Sew that onto the other eye. So, but somehow you have to have a way of closing the eye that you're turning into the donor, closing it while you sew the other eye, and then coming back and
even without that, with a very skilled surgeon, potentially, if one eye is truly an LP and the other eye is already post-transplant, post very recent transplant, one person could work on the good eye and the other one with loops could work on the NLP. That's an idea.
So maybe we can see the patients in the OT today, and we can move to the next patient. Maybe brief case presentation for the other patient.
Thank you.
Good morning, professors, doctors, fellow residents, and as well as our distinguished guests from the Eye Center. My name is Dila, and I would like to present our patients that will be conducted today on Kirana OT. So in total, we have 5 of our patients today, 1 PKP patients, 2 DMAC patients, and 2 dog patients. We'll start with the dog patients. We have 2 patients, Mr. RY, 26 years old, with lattice corneal dystrophy. Will be operating on his right eye today, and the second one will be Mrs. N, 53 years old, with macular corneal dystrophy and still have senile cataract in both eyes. We'll conduct a dog on the left eye. We'll start with the first patients. It's Mr. RY, 26-year-old, with diagnosis of lattice corneal dystrophy of both eyes. Patients actually came with blurry visions, especially on the right eye, 1 year prior to admissions. The patient's actual reports blurry visions described as if the vision on the right eye was covered by fog, which progressively worsening over time. There is no associated eye redness, tearing, or ocular pain, and the patient's currently on sodium chloride and potassium chloride 6 times per day for both eyes. The patient has no history of ocular surgery. Here's the ophthalmological examinations. The right eye of the patients have a visual acuity of 3/60, with RP of 11 millimeter hydrogen. On the cornea, we can see that it's 6.5 times 5.2 millimeter of cicatrix on the central cornea, with half the depth of the stroma. And here's the anterior segment OCT on the latest examinations. Then we'll proceed to the second dog case, Mrs. N, with 53 years old, with macular corneal dystrophy of both eyes. The patient's actually referred from the other peripheral hospital with complaints of progressively worsening blurry visions on both eyes, which actually has been experienced on the past 20 years. The patients also complain of pain and sometimes tearing and redness whenever the pain occurs. On the latest examinations, on the left eye, the visual acuity was 1/300 with intraocular pressure of 14 millimeter hydrogen. And we can see on the cornea, there's a diffuse opacity that involves the entire field of the cornea. And here's the latest anterior segment OCT on the latest visit. We'll move on to the DMAC patients. We have also 2 DMAC patients with Mr. H, 60 years old, and Mrs. S, 56 years old. For the first patients, for the first DMAC patients, Mr. H, 60 years old, with pseudophakic Billow's keratopathy. The patient just underwent a secondary implant surgery on the February of 2024. The patients also just underwent the secondary implantation on the last February. The visual acuity of the right eye was 3/60 with IOP 9 millimeter hydrogen. On the cornea, we can see there's a hazy and some microcytic edema, the somewhat fold, as well as some iris pigmentations on the endothelium. And here's the anterior segment OCT of the last visit. Okay, the last patients of the DMIC, we have Mrs. S, 56-year-old, with corneal dystrophy of both eyes. On the left eye, the patient had undergone phacoemulsifications, and they is still phakic on the right eye. The patient's currently on Carmelo 6 times per day and Siloxane 6 times per day. The patient actually has complained of blurry visions on the left eye since 2 years ago. Here's the last hospital visit. The left eye has a visual acuity of 1/60 with IOP of 8 millimeter hydrogen. On the cornea, we can see there microcystic edema with some of microbulae, and there's superficial neovascular lesions. On staining examinations, we can see that there's punctate staining all over the body. And here are the last anterior segment LCT and the last visit. Okay, thank you.
First patient.
Yes, this one's the latest lattice dystrophy patient.
Thanks. Great. So obviously, you know, the getting this successful doc will be helpful in terms of having the DMEC tissue for the other two patients. But both of these look like they should be pretty reasonable cases. In some ways, although DOLC is one of the primary indications is keratoconus, I do personally find DOLC a little bit easier in non-keratoconus patients because of the corneal thinning that you can get with keratoconus, and also because of how far it can bulge forward. That can make the angles of the cannula or the needle a little bit more difficult. Whereas in these cases, it's a relatively normal shape and thickness of cornea. It's just opaque. So, yeah. And both of the DMEC cases look like those both look pretty straightforward from the DMEC standpoint. So I think these look like great cases.
Okay. So thank you, Professor Williams. So I think we can conclude this meeting here. Yeah, sorry, Dr. Farabi.
Yes, Prof. Since this is one donor that will be divided into two patients, one is DOC and one is DMEC, and if the first patient is failed, we have to cancel the operations of the second patients. So what is our strategies regarding this? Or who is the first one that we operate, the DOC one or the DMEC one?
We should do the DOC first and then the DMEC, so that if we fail either to prepare the tissue or fail to, well, oh, I see what you're asking. It would be, I still think we should do the DOC first, because if we prepare the DMEC tissue well and do the DMEC and then fail at the DOC and need to do a PK, we wouldn't have anything left to PK. But and so the patient would be stuck. But if we, like halfway through the surgery, but if we fail at the DOC and have to do a PK, then we can just not start the DMEC surgery. So we're not failing in the middle of a surgery. And then we can work either with CorneaGen or with, next time I come, we can bring DMEC tissue specifically and put that person at the top of the list. I would think that would be the best way to do it.
Yes, thank you, Prof.
Okay. So I think we can conclude this meeting and we can go to the OT. Thank you so much, Professor Williams, Dr. Song, Dr. James, for the input. Assalamualaikum warahmatullahi wabarakatuh. Good morning.
Thank you to Professor Lloyd, Dr. Jessica, and our fellow residents for all the insightful presentations and discussions today. Next, we invite you to witness the live surgery demonstration where surgical techniques in corneal transplantation will be showcased in real time. This will be an invaluable opportunity to observe and learn directly from the experts. Before we close, we would like to extend our gratitude to PT Afina Sinar Cemerlang for the sponsor and making today's event possible. With that, we conclude day 1 of our program. Thank you for your participation, and we look forward to welcoming you again tomorrow for another enriching session. Thank you.